treatment of a complex distal radius fracture with Medartis implants. Performed by Professor Dr. Tim Lögters. Here you can see the preoperative CT scan. Due to the complexity of the fracture, a volar and a dorsal approach is mandatory. We will start with the palmar-modified Henry approach, identifying the flexor carpi radialis. Due to the complexity of the fracture, we will need a second dorsal approach where we identify Lögters tubercle. Now let's start with the Henry approach and carefully dissect down to the radialis tendon and open the tendon sheet twice above and under the tendon. This increases the mobility of the tendon and keeps the median nerve ulna and the arteria radialis radial protected. Holding the flexor tendons ulnawards shows the pronator quadratus, which is detached from the radius radialwards. In complex fracture situation, restoration begins ulnar with reduction of the ulnar main fragment. Here I use a Homan hook to reduct the main ulnar fragment and afterwards temporarily fixate the fragment by 2K wires. Now the radial main fragment can be reduced against the ulnar fragment and then temporarily fixate by 1K wire. For this fracture type, I use the APTUS distal radius adaptive 2.5 plate as it offers a safe fixation of the ulnar column. Here we see the alignment of the plate at the shaft and first fixation of the plate by a cortical screw in the oblong hole. After tightening of the surplate, position is controlled by vision and X-ray. Then the fixation of the distal fragments begins ulnar. Here I use 3 screws to fixation the ulnar column. The K wires are removed. Placement of a radial plate with detachment of the brachioradialis muscle. As the reduction of the radial fragment is not anatomical yet, I detach the brachioradialis tendon from its distal insertion. This reduces the tendon forces to the fragment and usually does not have an effect on the range of motion post-surgery. As the radial fragment is still unstable and dislocated yet, I reduce it again against the already stable fixed ulnar fragment and fix it with a second K wire. Due to the complexity and high grade of instability, a radial column plate is indicated. It is placed radial and temporarily fixed by K wires. Under X-ray control, the plate could be placed further distally, which is recommended for secure fixation of the fragment. A second cortical screw closer to the fracture further reduces the radial to the ulnar fragment, followed by a tri-lock locking screw proximally. Now the distal part of the plate is close adjacent to the bone and reduce the fragment. 2 locking screws, which are placed parallel to the joint space, fix the fragment. Screw length should be as long as possible, but must not penetrate the DRUJ. The unstable distal radial fragment is fixed by two tri-lock locking screws. The screws should be placed parallel to the joint space. Now, further fixation of the radial column is augmented by two locking screws. Thereafter, stability of the fragments and adequate fixation is checked direct under vision and X-ray. Skin incision in projection of Lögters tubercle. As fracture characteristic shows relevant dislocated dorsal fragments with destruction of the articular surface, a dorsal approach is indicated. Preparation of the extensor retinaculum and opening of the fourth extensor compartment. Preparation of the extensor pollicis longus and the EPL tendon is mandatory. I regularly perform a denervation by segment resection in distal radius fracture cases with dorsal approach. Thereafter, the posterior interosseous nerve on the bottom of the fourth compartment is prepared. Fracture fragments are carefully visualized, fracture space irrigated and fragments reduced. Here I do fracture reduction without incision of the dorsal capsule, which is sometimes necessary. Thereafter the dorsal frame plate is placed safely below the extensor tendons and temporally fixed by K-wires. The plate is then fixed by cortical screws. If a volar plate is already in situ, screws of the dorsal plate can only inserted monocortical and more screws could be necessary to fix the plate safe onto the shaft. Now distal fragments are fixated with locking screws. Screws should be placed parallel to the joint space. That means along the dorsopalmar angle. Mobility check after screw placement. Radially, a small osteochondral fragment attached to the capsule could be fixed by a suture at the plate. As the dorso-ulnar fragment is still unstable, a hook plate is indicated. First, the fragment is reduced and fixed by a K-wire. The dorsal capsule is incised and the hooks are placed. So the plate stabilizes the dorsal corticalis. The plate is fixed by two 1.5 speed tip self-drilling screws. Thereafter the K-wire is removed. The X-ray shows an anatomical reduction and a good implant position. The extensor retinaculum is reconstructed. If the motion of EPL tendon is disturbed by the plate, a supraretinacular transposition of the tendon should be done. Subcutaneous suture with Voicryl 3.0 is used. Mobility check at the end of the operation shows free range of motion.